Thank you so much for joining me today.
It's an absolute pleasure. And I'm trying to figure out who's more excited, you or me.
Oh, I don't know. I think we're both equally
I
excited. We've
think
been
I think
working
we're
in this
both off
space
the
for a long time,
scale.
right? Yeah. Um,
Unquantifiable.
so before I get ahead of myself, can you explain what news was released yesterday by UniQure?
Oh, I don't know what you mean. What news? I don't know what you mean. No, I'm kidding.
No.
So
I love it.
I can never resist a dad joke. So the news that was released was from the first gene therapy trial for Huntington's disease. The company behind it is UniQure, originally a Dutch company, now Dutch and US. And fun fact, the AMT, an AMT 130, I believe stands for Amsterdam Medical Technology because that was the original name of the company. But the company is now called UniQure with a Q. And the results that were announced were the 3 year time point. So the result of the patients in the trial being treated each for 3 years. And 3 years is a very long time. A normal Huntington's disease trial, like the longest trials we run, tend to be 2 years because that's how long it usually takes to figure out in a large group of people whether a drug is working or not. A gene therapy trial is very different because once you've been treated with a gene therapy, it's in the body and it stays active for the rest of your life. What that means is that you can run trials that are very long and allow time to be the thing that gives the trial its power. And we know that something like the placebo effect, which can really get in the way of a short trial. So if we treat people for 6 months and they're better at the end of it, there's a good chance that that's simply because they know they're in a trial,
Right.
and that the placebo effect makes people feel better, and in some cases makes their body work better. So with a 3 year trial, there's no way really realistically that the placebo effect can outpace the progression of Huntington's disease over 3 years in people who already had symptoms at the start. So part of the strength of this study is that it's really long. It's also because it's a gene therapy, and it's which we'll go into no doubt. It's active 24 hours a day. So when you take a pill, or the level goes up and then it goes down, and then you take another pill. So it's constantly going up and down. Injectable therapies that go into the spinal fluid may be given every 6 or 12 months. So that's kind of a lot of up and down, whereas a gene therapy is produced inside the cell and it's 24/7. So I think that goes some way to explaining what we've seen. But so yes, this was the 3 year time point from the UniQure AMT 130 gene therapy program, and the results were quite eye-opening. And I think it's safe to say, speaking for myself and basically everyone else I've spoken to, 75% slowing of clinical progression of HD is a result that is dramatically beyond what any of us could have wished for or dreamed of. And that 75% is on this measure that we call the composite UHDRS or CUHDRS, which is a single number behind which are separate measurements of movement and functioning, daily life functioning, and cognitive function. And when you look behind the headline figure, virtually every one of those individual measures is significantly improved as well. So there is a 60% slowing of loss of function. So that's things like people losing their jobs or not being able to do the housework. Um, One of the cognitive measures is 15% better at the end of the trial than it was at the beginning. So that's the only way that the sponsor can describe that scientifically is 115% slowing
Right.
of cognitive decline.
Which was crazy to
The
me. Yeah.
cognitive decline is no longer a decline, it's a 15% cognitive improvement. And the motor score didn't achieve what they call statistical significance, but it seems to be on the way. And what's more, if you look at the graphs between the year 2 and the year 3 time point, the gap between the treated patients and the natural history comparison arm from Enroll HD is getting bigger. So there's no sign, the effect of the drug doesn't wear off between year 2 and 3. The effect appears to be growing. The lines are diverging. And finally, one of my favorite measurements, neurofilament light,
Hmm.
which is a measure of whether we are slowing down the rate at which neurons are dying. Are we rescuing neurons? If the neurofilament level goes down, that means neurons are being rescued, broadly speaking. If it goes up, it means neurons are being harmed. And we would expect over 3 years a 30% increase in neurofilament as HD progresses. What we're seeing instead is an 8.5% decrease. So, in other words, these patients are nearly 40% lower in their neurofilament than we would expect at the 3 year time point, which, in combination with those clinical findings,
It's
really
incredible.
is. It's a totally compelling and convincing package that says we are slowing the progression of the disease and we're doing it by rescuing neurons. So essentially, it's Huntington's disease is always a tug of war
Mhm.
between the protein doing damage on one hand and the brain's ability to deal with that damage on the other. And if my right hand is the protein, what we're basically doing is really diminishing the strength that the bad side of that equation, that tug of war can pull. And that, obviously gives a huge advantage back to the brain. It's the kind of advantage that the brain has for all the years before the symptoms emerge, because in the very far from onset stage of the illness where people don't have signs or symptoms, but the gene is doing stuff and the protein is doing stuff. The reason people don't have symptoms is because the brain is compensating for the presence of the
Right.
harmful protein. So what we're doing is essentially reducing the rate at which new harm is caused, and the brain is therefore able to um,
Compensate.
withstand the effects much, much
Yeah.
better.
And it's incredible.
Yeah,
I-
right though. And I think it's a really important point, Lauren, about how the community has got us to this point. And let me use as an illustrative example the way the results were presented and how we know the drug is working. So because it's a gene therapy, there isn't an ethical way to run a placebo arm. Normally, in a clinical trial, it's randomized, which means people are allocated to treatment or placebo at random. It's also blinded, and the placebo arm is run in parallel, and no one knows whether they're in it or not. And at the end of the trial, you compare the active treatment to the placebo, and that's how you know whether the drug actually works or whether it's just making people feel better. You can't do that for gene therapy because we need to run this trial for 2, 3, 4, 5 years to allow those lines to gradually diverge. And if you in the US, there was actually a placebo surgery arm at the beginning where people just had an anesthetic and incisions made into the scalp. Um, but eventually, it was decided that that wasn't worth carrying on with because you couldn't take those people beyond 12 months ethically. They all had to be offered the opportunity to be given active treatment. Um, so what that means is that at this 3 year time point, there's no placebo arm. So what we have to do is try to put together a group of patients with HD who look like the patients in the trial but don't have the treatment. And that's where the Enroll HD study comes in. We already know the Enroll HD study, which is run by CHDI Foundation. We already know that that has given us some of the most important genetic insights into things that accelerate or slow the progression of HD. This is Enroll HD's moment of glory, and I think this week really justifies every single Enroll HD visit. Anyone who's ever been to an Enroll HD visit, done the test, done the, fist edge palm, all of that, follow my finger with your eyes, all of that.
Yes. Yeah.
Not glamorous, but absolutely crucial because from the 30,000 people in that study, 900 and something were selected for being a very close match to the people in the UniQure study. And how we know the UniQure gene therapy is working is because we compare them to what happened to those Enroll HD participants over the 3 years that they were followed. And we absolutely wouldn't be where we are if it weren't for Enroll HD. And the broader picture is that even Enroll HD is not something that everyone can participate in. But we have this trial result because we are a strong and vibrant community that supports itself and supports each other. And we bake cookies and we go on walks of hope and we do hoopathons and fundraise and people take their friends and relatives to clinical research visits. And all of that's essential for bringing a community to this point. I would, I would also like to mention, if I may, by name, Mr. Charles Sabine, who I know you know, good friend of
Yes.
mine and a patient in London, one of the most effective advocates in the world for Huntington's disease, and part of why UniQure got into Huntington's disease in the first place and chose to commit hundreds of millions of dollars to HD is because of Charles uh, speaking to the UniQure team and convincing them that not only was this a terrible disease, but also a disease that should be high priority for treatment because it should be treatable. And and also a disease where the community is ready for this kind
Yes.
of advanced trial. What result was. So the UniQure result gives hope across the field that we will now, I think, start seeing further successes from the other Huntington lowering trials.
Yes. Which, I really want to stress that, guys. Like, this doesn't negate anything that's being done in other clinical trials. In fact, it truly helps to direct things. And we now know that Huntington lowering works. And
Mhm.
so the other sponsors can use this information for their trials. And
Exactly.
these are
Yeah.
things that hopefully in the future we can look at pairing. And, I know before we've talked about cocktails, of medications, which we were just discussing before. So, um,
Yeah, and I think that's a potentially useful thing to mention is that obviously for combination therapy to be a possibility, you have to have multiple drugs that work, and to have multiple drugs, first you have to have one drug. But if you just think about the anatomy, this uh, gene therapy is treating a small area of the brain that's really important in HD called the striatum. And some of the gene therapy probably then moves down our neurons, or I'm saying down, but moves up our neurons into the cortex. But it's treating a relatively small part of the brain. Uh, so it's possible that in 10 or 20 years, the patients who've had this gene therapy might start to develop a weird form of Huntington's disease that we don't recognize because the striatum's okay, but the cortex has started to experience problems. It's likely that would be a much less severe form of HD, but also the cortex happens to be the part of the brain that is particularly well treated when you inject a drug into the spinal fluid. So we could imagine a future in which people have a gene therapy operation as a starting point, and then later on, if necessary, based on blood tests or scans, we could add an ASO, the like tominersen, to treat the cortex. So it's I think that's something we did. Each drug has to be tested separately, but then in the real world, we use drugs in combination or in sequence all the time. And that approach is always tailored to the individual patient rather than based purely on the numbers in aggregate from a big trial.
yeah. Let's talk next steps because, as I
Mhm.
was saying yesterday to people, I celebrate the wins as they come, and then the next day is all for solutions to the barriers, and we certainly still have those. So let's talk about next
Yeah,
steps. What does that look
yeah.
like?
So the next steps are already underway. Um, the first thing that the sponsor UniQure will be doing is entering into a conversation with the FDA. They've been in conversation throughout the program. This drug, because it's the first gene therapy, has something called RMAT or RMAT designation. I can't really remember what it stands for, but it basically gives priority access to the FDA for innovative therapies in diseases that have no effective treatment. So, and it sort of turns the FDA into more of a partner than someone who just says yes or no when you present them with data. So after they presented really nice results, promising results last year at the 2 year time point, they then entered into a long dialogue with the FDA saying, what do we need to show you in order to get approval? And what form would you like it in? And the analysis methods and things like using the Enroll HD as the comparator arm, that was all developed in discussion with the FDA. So what that means is when they go back to the FDA to start the conversation about accelerated approval, they already know that what they've done is the kind of thing the FDA wants them to do. But these things do take time. So first step, get the drug licensed by the FDA in the US. The timeline has been shared, so the initial meeting will be before the end of this year, and they plan to submit the official filing for priority review in the first couple of months of 2026. I don't know if you remember, it was probably 2014. We heard that the spinal muscular atrophy (SMA) had its first licensed drug, and that was a
Yeah.
trial that stopped in September, I think it was August or September, and the drug was licensed by Christmas in the US. So we do know that the FDA, if they're presented with strong data in the right context, we do know that the FDA can work quickly. Of course, there's being licensed and there's being given to people, and those are two different things. So money will be one issue. This treatment's probably going to cost in the neighborhood of about $2 million a person. That's based on previous gene therapies. But that it's obviously a lot of money, but we're already spending a lot of money to keep people with Huntington's disease cared for, to manage the symptoms, to provide assistance to their families, to residential and care home facilities, and all of the medications and everything. So it's an expensive disease to deal with already. If we have a drug that costs a lot up front, but could give people decades of disease-free life or high quality life, then the mathematical and economic side of things really starts to become obvious. I did a back of an envelope calculation. It may not be accurate, and even if it's accurate in theory, it may not be borne out in practice. But I reckon if you imagine someone who's expected to develop symptoms of HD at the age of 40, and they can test and have a gene therapy at the age of 18. It could be earlier, but for the sake of argument, we'll say 18. That's 22 years. And the disease is progressing. Even though the person has no signs or symptoms, the disease is still progressing inside the head from birth. So between ages of 18 and 40, that's 22 years. If you slow that stage by 75%, that 22 years becomes, I think it's 88 years. So that person can expect not to have symptom onset of HD unless they live to 108 years of age.
Wow. Well, not to
And
mention the fact that several of us would be able to stay in the workforce when we
exactly,
couldn't.
exactly. So so many carers and partners have to leave work to look
Yep.
after their loved ones. And again, that's to put it in bleakly capitalistic terms, that is lost tax revenue that could
Yeah.
be used for healthcare.
Yeah.
Yeah.
Yeah. So ultimately, not that much when we're looking at the long-term
No,
cost of
exactly.
HD.
Fingers crossed.
So let me ask you another question that I keep getting, and that is people who would be eligible for it, because
Mm.
obviously those in this study were stage 2 and stage 3. So is it likely that it will only be for those stages, or do you think that we can
No,
actually argue?
it's difficult to predict, but it's certainly the case that everybody wants what they call the label to be
Mhm.
as broad as possible. So we would rather, and we will be asking the FDA to give a label that says Huntington's disease. So then you can give the drug to anyone with Huntington's disease, and that would include uh, people who have the mutation that causes HD but don't have any signs or symptoms yet. And I think that discussion will be made easier by the development of the integrated staging system
Yeah.
with the HDISS, because that makes it very clear that the scientific understanding of HD is that the disease process begins at birth and ends at death. And signs and symptoms of the disease emerge when the brain starts losing the battle against the presence of the uh, protein. But the damage is building up, and that is Huntington's disease even before it causes signs or symptoms. That argument, which the FDA seems to be happy with, does suggest that if the drug is licensed for Huntington's disease, we could give it to people who have the mutation at any time. And it stands to reason. And we also do have evidence from other programs like PTC and the Tominersen program. The earlier you treat, the more likely you are to be successful. And certainly with a gene therapy, you treat once, it stands to reason that that would have a more potent long-term effect if it's done early rather than late. But let me be clear, I I'm not saying, nor do I intend to say, that we won't treat people with symptoms or that there's no hope that this drug will help people who already have symptoms. None of that is known yet. And that may be something that we end up exploring after the drug is approved in the real world. Accelerated approval comes with the requirement that the sponsor monitors the real world effectiveness of the drug. So it's not like just getting antibiotics and then what happens next is between you and your doctor. When a conditional approval or rather an accelerated approval takes place, the company has to collect data from every patient who has the drug, analyze those data, and keep giving the FDA updates. As long as the drug is working as it is expected to, uh, that's fine. The drug stays licensed. If it doesn't perform in the real world how it's expected to perform or how it performed in the trials, the FDA will remove the license, and that has happened. But what that means is that we may actually end up with the freedom to explore treatment throughout the full range of HD from birth to manifest disease.
So for those who are concerned that after stage 3 there's no hope of getting this, it's not the case. And not the case with other clinical trials as well. You know, I don't think that anybody is of the opinion that we should be just forgetting about our more advanced HD people.
No, no, absolutely not. And one of the really eyebrow-raising results from this program was that on one of the cognitive scores, which is called the Stroop word reading task, it's just reading words off a piece of paper. The the performance in that was better at the end than it was at the beginning. So those people actually improved during the course of the trial. So that's 100, they called it 115% slowing, but what that actually is a 15% improvement at the end compared to how the people were doing at the beginning, which is a real testament to the brain's ability. If we can make things a little bit easier for the brain really wants to recover. And
Yeah.
it's certainly not out of the question that we might start seeing consistent increases in functioning, performance, and motor scores, and so on. Can't promise it, but it seems entirely within the realms of what we now know to be possible. Com Companies exist. Part of what they exist for is to make profit, but it's a really difficult way to make profit. And so they're in the business because they want to make drugs that work. And if they can make profit from it, then that's also great, and I'm happy for them. But the crucial thing is that no company wants to make a drug that either doesn't work or that ends up not being able to be given to people for whom it might work. So the first time we run trials, the population's always really narrow, because if you have a narrow population, you don't need so many people to find out whether the drug is working. If you've got a really broad population at the start of the trial, you need many more times the number of participants in order to show whether the drug is working. So the trials will be very focused, but in the real world, we want drugs that can be given to as many people as possible, and certainly people who don't match the exact criteria in the trial. So that's a case that we need to make to the agencies. And there may be a need to run additional small sort of add-on studies or biomarker studies. For instance, we may need to show in a small group of people before disease onset or manifest disease to show that the neurofilament goes down, even if we can't measure clinical change in those people because they don't have any signs or symptoms of HD. And we're up for all of that, because what that is just kind of putting flesh on the bones of what we already know is a winning recipe.
Yeah.
We know for the first time that this is a solvable problem, and not only a problem that can be solved a little bit with great difficulty, a problem that can be dramatically improved. And as time goes on, the methods that we have for doing it will only get better and better. You know me, I'm always upbeat, even when things are terrible. But right now, I feel like the real world has caught up with my level of optimism and enthusiasm. It's like the gene therapy heard me being relentlessly optimistic and was like, fine, I'll slow it by 75% then.
It's so funny because I did a video yesterday and I said, well, they did exactly what I asked, and that is they they gave us time, because
Right.
I've often said for me it's not about now being in this prodromal phase, and it's not about a cure so much as buy me some time until we can get to the next
Well,
thing and
that's
the next
exactly what it
thing.
is. And, this is how it was with HIV in the late 80s, early 90s. The first treatments that were available weren't great. They only worked for a little while. But that was enough to keep people alive a bit longer. And in that extra few months, another drug came along and another and another. And now people with HIV, can have an injection every 6 months, is it, or a year? And that's it.
Yeah,
So, science is cumulative. Uh, I've been
yeah.
saying that for quite a while as well.
Well, and this proves it, and it's also
Yeah.
exciting. I'm right there with you, and just my excitement and passion about this, and I am really looking forward to the next days ahead as we find out more from FDA,
Yeah.
and how
And anyone
they
in your audience
proceed.
who's attending the Clinical Research Congress next month in Nashville, first of all, that's going to be a massive party. Second, that's when we can expect the first direct presentation of the results to the HT scientific community, and there'll be lots of discussion about what it means and how we make this a reality.
Awesome. Well, Ed, thank you so much for coming on and talking about this for the community. And I am so grateful to you for all that you do, for also breaking things down for us and making it so everybody can understand, and for continuing to fight right beside us.
It's my pleasure. As you know, I'm not from an HT family, but I very much have skin in the game. And this is really just the start of, it's day one of a new world. But it's up to us to define the characteristics of that world and make sure that it's capable of delivering the benefit to everyone who needs it. And I do include very specifically people like the villagers in Venezuela who were so instrumental in discovering the gene, and are still living in terrible suffering, and need of much more help than they're currently getting. No one is free until everyone is free.